Thank you so much. So Santosh given me a job of how to triangulate a patient for an appropriate procedure. So before starting, I just want to highlight there are different types of refractive error. There is myopia, hyperopia, and astigmatism. So first in the year of 1995, we started PRK. Then 2001, we started femtoLASIK. Flex, we started at 2007. Small incision lenticular extraction started at September 2011, which has been US FDA 2016. 2018 is a compound myopic astigmatism. And 2024 Smile Pro Visumax 800 has been launched. So coming to the PRK, there are two types, alcohol assisted and trans PRK. These are some few of the issues with that post-operative pain, haze and regression. So with the microkeratome, LASIK used to be done, that is AIOS2 and Moria. There are the two popular microkeratome available. So we need to be always make sure that if the keratometry less than 41, always chances of free cap will be there. And more than 46, chances of buttonhole will be there. So this has been minimized with the femtosecond LASIK, which is bladeless, more accurate, can customize with the flap size and the thickness. So coming to the customized LASIK, that is wavefront optimized, wavefront guided and topo guided. So this is what why we go for wavefront guided, because of the no spherical aberration, which is based on the keratometry and the refraction that minimizes the spherical aberration, and also additional pulses in periphery and does not correct existing aberrations. So wavefront guided, which is based on the aberrometry on a higher order aberration treated on the cornea, that removes a lot of tissues, which is pupil dependent and accommodation dependent. Coming to the topo guided, started to treat irregular corneas, ablation pattern based on the topography, which saves a lot of tissues. So these are normal flexes. In femtoLASIK, what will happen sometimes, because of the cutting of the nerves, there will be a poor biomechanical stability, dry eyes and flap-related issues, which has been minimized in Smile. So the advantage of Smile, which is a flapless single step femtosecond procedure, the incident of less dry eye and biomechanically stable eyes. So coming to the 1 or 2 words about the presbyopia correction, you have got a Presbeyond, Presbymax and Supracore all on the corneal platform. On the less based platform, you have got multifocal IOL, trifocal IOL, you got EDOF. So 1 or 2 words about the Presbeyond, which combines both micromonovision and increased depth of focus by using MEL 80 or MEL 90 examiner system with the help of CRS master. Basically, you have to treat both the eyes, and 97% of the patient, they adopt this treatment very well. We make the dominant eye emmetropic and make the non-dominant eye myopic by 1.5 diopters, with where there is a blend zone where the vision from both dominant and the non-dominant eye meets up. So coming to 1 or 2 about the inlays, camera inlays are the most common one. We put it in the non-dominant eye under the flap. So the one more procedure, extra procedure, has become more and more popular. Especially it gives a stiffening effect only, no refractive effect. Especially patient with a thin pachy and early keratoconus, he can do this extra along with the Smile. So if patient is not suitable for keratorefractive procedure with the high myopia, dry eyes, extreme steep flat corneas, keratoconus, then the next option is the implantable phakic lenses. There are different phakic lens has been angle supported, iris fixated and posterior chamber. These are the few of the companies which is available. One is from the Colomar background and other one is all with the hydrophilic acrylic. So to achieve the best phakic IOL outcome, two very important, one is the antechamber depth, second one is the wide to wide diameter, and also perfect loading and intraocular insertion of the lens. These are the few advantage with the phakic lenses, with fewer induction of the higher order aberration, improved night vision quality, less dry eye and minimal wound healing and faster visual recovery. So keratorefractive surgery not suitable to ICL, or then you can opt for bioptics or refractive lens surgeries. So bioptics is a combination of laser and the lenses. Still patient not fit, then you need to think about refractive lens exchanges. So surgical option for refractive error have come a long way since 1990, which is more sophisticated, patient friendly in coming years. So coming to the main step, workup. So history, examination, investigation planning is very important. So preoperative counseling always very important. Always you should involve parents and attenders. Build and trust the patient with the patient. Very important. You can show them the booklets of the previous results. Then you need to ask the occupation of the patient also, very, very important. And you need to take a refractive history since when he is wearing the glasses, and also history of presbyopia. Coming to the contact lens, those who are using the contact lens, you need to ask them. You need to stop the soft contact lens 1 to 2 weeks prior to the refractive surgery, and RGP or hard lenses 3 to 4 weeks before the surgery. So you need to ask for the ocular allergy history, ask for any eye rubbing, infection, and also ask for any ocular trauma is there. Especially you need to look for retinal tears, optic nerve atrophy, and also lens subluxation. So especially patients those are already having glaucoma, you need to always look for there will be steroid responder. Sometimes when you are putting a LASIK, suction pressure also it may increase and it may damage the optic nerve also. The advantage with SMILE, you will have a soft docking. So those who are already undergone previous glaucoma surgery, you need to look for bleps also and family history of glaucoma. That is very, very important. Look for any of the ocular surgery previous happened, whether cataract surgery, retinal surgery. Some of the patients never tell that they come to, they might have had a RD surgery, it might be having a 6/6 vision. So you need to ask about everything. You need to ask the patient whether they are already have undergone the squint surgery. They may have a suction conjunctival scarring. Sometimes you may have find difficulty to put a suction ring. So in fact, you need to even ask a patient already whether they are undergone the pterygium surgery also. Those patients also will have a conjunctival scarring. So coming to the medical history, very, very important. You need to look at whether they are diabetic or not. So then other thing is you need to look at the whether they are hypertensive, whether it's controlled or uncontrolled. Then you need to look at the pregnancy history, corneal parameters changes during the pregnancy. Always plan refractive surgery 6 months after the feeding over, and 6 to 12 months after the surgery, then you plan for pregnancy. This is important. So plan for pregnancy, and after pregnancy 6 months treatment is very, very important. Then always look at the patient having whether other systemic condition like rheumatoid arthritis, multiple sclerosis. Then you need to about the wound healing and whether they are suffering from other disease like morphons. So also you need to ask about the drug history, whether they are on anticoagulant and whether they are on antihistamine, or whether some of the drugs may have a very poor healing also. Then whether they are having a somatotryptan where they may have chances of vascular occlusion, and patient even with the immunosuppressants they may have a chances of infection will be very high. So this is very, very important. Then you need to ask about the history of epilepsy and 12 months quit the disease. Then you need to ask about the especially for those are already underwent cardiac pacemakers, and also whether they are on any of the implants. So this is very, very important. Then also ask for any herpetic infection, reactivation changes, and also whether they are on any of the prophylaxis for treatment. So coming to the examination, very important slit lamp examination. Always do a cycloplegic examination for the first time, especially for hyperopia. Now look for pinhole also, and you need to look at for every refractive patient about the dominant eye testing, very, very important. Then this is how you look at the patient, especially torchlight examination, very important, where you look for all orbital anatomy for small eyes, deep setted eyeball, prominent cheekbones, prominent nasal bridge, and also look for any of the squint and ptosis. So examination very important. So the slit lamp, you look at the lid, conjunctiva, cornea, tear film, lens, uveitis and antechamber depth, and also you do the intraocular pressure measurement, 90D examination. So dilator fundoscopy is very important. You need to look at glaucoma, or you need to look at the macular pathology, peripheral retina pathology. Always look for retinal break. Treat the peripheral retinal breaks accordingly. Counsel about the post-op prognosis also. So dry eye assessment is very important with all these tests. For every patient you have to do a Shermus, T-BUT, meibography and inflammatory markers. Then corneal topography is the most important workup to know about anterior and posterior elevation maps, to know about the anterior curvature map. That helps in especially detecting the early and the suspected ectasia, and also plan for the topo-guided customized treatment. This is about the at-risk corneas, what you can see in the this one. What is at-risk corneas? Always keratometry reading more than 48 is at risk, anterior elevation more than 12 micron, posterior elevation more than 16 micron is very, very important. So what should be the post-operative expected key? That is myopia 0.8, hyperopia 1.2, and that is between, you can do around between 34 to 48 diopters. So suppose for example refractive error -8 diopter, then your keratometry may drop to 35.5. So this is about the pentacam picture. So pachymetry 500 micron. So always this is the Munalin for formulas. Always you need to look at how much every 1 diopter ablation in patient with 6 mm optical zone, then 13 micron will go. Then if it is 6.5, 15 micron will go, 7 mm, then 17 micron will go. So that is very, very important. Then other important factor is residual stromal bed. Always it should be around 300 only. Suppose if the, for example, if the -2 diopters, 2 into 15, that means plus -120 for the cap, that means patient is going to have a 344 residual stromal bed. This is how you calculate about the residual stromal bed. So apart from this, the one more important point you need to look about the percentage of the tissue altered, that is a PTA. PTA is equivalent to the flap thickness plus ablation depth divided by the central corneal thickness. So more than 40% of PTA, that is percentage of tissue altered, that means don't do the refractive surgery. If it is less than 40%, then you can plan for the refractive surgery. This is how. Then antechamber depth always should be more than 2.8 and white to white always between 10 to 13. So A scan to be done to know the ACD also. The other two factor pupillometry is very important. Always optical zone should be always larger, especially they will have a lesser aberrations. Then you need to look at the endothelial count of the patient also. These are the few investigations. So apart from that, you need to do the aberrometry, especially this is the one machine with iTrace. I don't have any financial disclosure that will know about the corneal aberrations, internal aberrations, and also dysfunctional lens index. So you can know the aberration profile also, so that you can plan. Then other equipment we can also help you, that is about the Corvis, where you can assess the biomechanical assessment to identify the risk corneas. So coming to few of the case scenarios I am showing you. Case number 1, this is a 24 years old female. The patient right eye refraction is around 2 and 2.5 diopter with the 1 and 1.25 cylinder. Central cornea thickness is around 4, right 497, left 500. So this patient, he can do any of the everything is normal. You can opt for either for LASIK, or you can opt for PRK, or you can opt for SMILE also. So case number 2, 30 years old female, football player. So normal pentagram. So you can either, since he is a contact sports, the SMILE or PRK is the best available options. Then case number 3, 31 years old female with high refractive error 11.5 minus 12 diopters, but ACD is very good 3.2 and left 3.1, then I think you should plan for phakic IOL. Case number 4, 24 years old female, minus 19, minus 18 diopters, but ACD is very poor, no laser, no ICL. If patient doesn't want to wear the contact lenses, then you should ask him for a refractive lens exchange. Then case number 5, 28 old female having a allergic conjunctivitis, eye rubbing. You can see the pentacam report not favorable, minus 3 with minus 3.25 cylinder, left eye minus 4.5, 5.5 cylinder, CXL you have to do, no refractive surgery for this patient. The case number 6 I am showing you, 23 years old male using spectacles, right eye minus 4, left eye 3.5, specular, early fuchs, but still asymptomatic, then you can still plan for PRK, LASIK, or even for SMILE. Case number 7, 27 years old female with a pure cylinder, right 2.5 90, left 2 cylinder at 90, All other parameters are normal. So you can plan for smile after transposition, or you can plan for femtoLASIK or LASIK. So this is the last case. Male patient, 29 years, so history of spectacle 8 years, minus 3.25, 1.5 cylinder, left eye 3.5 with 1 cylinder, pack is very less, 434, 445, but ACD is very good. You can go for a phakic IOL. So always informed consent is very important. Pre-operative counseling, assess the patient expectation, explain the realistic goals along with the rare chance of complication of treatment, involve parents and attenders in the counseling process, build trust and rapport, promise less and deliver more. So 2 to 3 hours of detailed assessment for 5 to 10 minutes of procedure, which is the mantra for success. Thank you. I thank Dr. Santosh Honavar and all AIOS governing body for this opportunity. Thank you.